Okay, so I'm sorry about that. Somehow, it was there in the speaker ready room, but I couldn't see it here. So I've been using the ICLs for more than 20 years, but the IPCL only for the last 10 years, and it's come a long way. And as we all understand, refractive surgery has been evolving, and you can have corneal-based refractive surgery, which has again been around for quite some time, and it has again evolved a lot. And then it can be a lenticular refractive surgery. We can have a combination of the interiors, and then of course the other advanced protocols as well. And it was way back by Dr. Fyodorov, who had proposed a collar button mushroom configuration for a phakic lens made of silicon. That was in the year 1986. And he was, of course, a prolific figure in Moscow who also founded refractive surgery in the form of radial keratotomy, which became very popular in those 2 decades. He had laid the foundation for the design for the phakic lens of the posterior chamber. And IPCL was became available commercially in the year 2014, and the version 2 with the central hole and the other holes was launched in 2017. I started using this somewhere around 2015, and today I think IPCL from the Care Group in India is exported to almost 40 countries. And so these are the specifications. It has a central hole which is about 380 microns, and it has a central thickness of only about 80 microns for all the diopters. And it has a special haptic design, which I will talk about a little bit, and water content of 26%. With the central hole, you don't need to do the PIs. And it has been shown to have very little endothelial cell loss over a period of 10 years studies. Now, the good thing about the lens is that it has spherical powers right from -1 to -30 in steps of 0.5, and also from +1 to +15. So the range of correction is much higher, and also of the astigmatism from 0.5 to +10 in steps of 0.5. And also additional powers in the presbyopic lens, and you can put it from an incision size of just about 2.2 to 2.8. It also has the advantage of having steps of 0.2 in the size as compared to the star ICL, where the steps are much bigger. So your flexibility on sizing is much better. The other difference from the star Vision ICL, which also I use in good numbers, is that the central hole here is about 20 microns bigger, and also the design is slightly different because it's a conic hole rather than a cylindrical hole which is there on the Vision ICL. So this allows for less scattering of light from that central hole. So the chances of getting the glare and that small haloing effect which comes is much less. Again, another advantage is with the haptic design, which makes it less dependent on the white to white. So the tolerance is better for this model because it allows a little bit of more play for undersizing and oversizing, so that it will not cause a very high vault or a very low vault, and it tends to fit the sulcus in a much better way. So this is the flexible spring effect of the haptic pads, and also the material is much more biocompatible. Now the indications remain the same as for all phakic lenses, so it can be used for both kinds of ametropia with and without astigmatism. I have used it in a few cases of keratoconus as well, where we have had stable astigmatism, stable correction over a period of 2 years. It can be used. Of course, the sizing remains to be more accurate in these cases because you will have a falsely high AC depth. So your sizing has to be more correct. We have also used this lens as a piggyback lens in pseudophakic patients for correction of refractive surprises. Has been used for post-corneal transplant surgery, and also the presbyopic version is now available. I'm personally not using it, but it has been used by quite a few of my colleagues. Again, stability of refraction beyond the age of 21 years, clear crystalline lens, and contraindications would be also there, but pupil size is very important with good AC depth of minimum of 2.8. You would want to aim for a vault of 250 to 750 as with the other phakic lenses. And again, no ocular pathologies like corneal endothelium compromises, iritis and iris atrophies and glaucoma. We discussed about this in the morning. These are all the contraindications. So if your refractive error is not stable, or if your endothelial counts are poor, a very narrow anterior chamber, and any kind of early cataractous changes would disqualify such patients. So going to the surgical technique, I think it's not very different from our usual phakic lens technique, and I'll just show you the preoperative investigations. I like to do a thorough investigation with a proper thorough slit lamp exam and a gonioscopy, a good topography as well, and optical biometry, because today we can do better sizing of ICLs using optical biometers. A white to white measurement is critical for success because the formula for the ICL sizing requires that. a good glaucoma and a retina evaluation as well. And then there is this software which is available, which can be used by putting in the data of the what you've done in the preoperative exam, and it will give you the sizing for the ICL and the rotation sheet as well. So the cartridge is much easier to use than the star version. I always find that the butterfly cartridge which comes with the IPCL is so much more easy, because for cataract surgeons to load the lens. And this is a video from my 2015 surgery. Why did it go away? So this is the version 1, which did not have a central hole. So you can see I'm marking the toric axis over there, and following that you can implant the ICL. I'll make a 2.8 millimeter incision, and a similar kind of injector as we use today, and this can be injected in and then put on the axis. The good thing is that this lens is a smart toric, so you don't have to do much rotation. These lenses come already always designed to be implanted at 180 degrees. This is a big advantage, because when you order an IPCL, you have to provide the refractive data, and the IPCL always comes for implantation at 180. So for beginner surgeons and for those people who don't have access to other means, this becomes much easier, and then you can basically implant the haptics under the iris. It's fairly easy with the manipulator. You can see those 2 extra holes over here. These are always to be towards the superior side. So the implantation, these are the landmarks which can be used for correct orientation of the IPCL. And since it's always implanted at 180, it becomes so much easier. This is how it looks post-operatively, and good vault over there. The version 2, which came out a few years after the version 1, has a central hole, which makes then you don't need the peripheral iridotomies. And this is another patient where we are implanting the IPCL. Again, the loading is over here. It's fairly straightforward and much easier than the star ICL. Once you get used to doing it, the star one is also fairly easy. But for a beginner surgeon, I feel that this is much more intuitive and much easier to do. So if you noticed, the first surgery, it was done under viscoelastic. Now for the last many years, I implant my lenses under infusion. I don't use viscoelastic because that helps me, it saves time in towards the end of surgery in washing the viscoelastic away. And also it minimizes the risk of IOP spikes following ICL surgery. Also minimizes the risk of anticapsular inflammation from retained viscoelastic, which could cause lenticular changes, and also minimizes the risk of TAS. So in many ways, it comes out better. So here you can see in my left hand is the infusion, and the infusion is on. I have not used viscoelastic fill in the chamber, and I'm injecting, and you can actually rotate this a little bit if you see that the ICL is opening a little bit twisted. Sometimes it twists as you push it in the cartridge, and you have to definitely watch out for all the landmarks so that it opens the correct way. These 2 holes should always be towards the superior 12 o'clock position, and then there are also other landmarks on both the haptics, the leading and the trailing haptics. You can see that all this is being done only under infusion, and the chamber remains fairly well formed. And then you can tuck in the other 2 haptics and then orient it at 180 degrees. As I said, you always have to orient these lenses at 180 degrees. Sits very nicely. And once the haptics are in place, you just rotate it a little bit to 180 degrees. So not much rotation is required. And then you can do intraoperative OCT to see that the vault is sufficient. So if it is not too high or too low, you can, in this patient, the vault is about 700 to 800 microns, which was fine for us. And then you can seal the chamber. So the surgery is over in barely 2 minutes. The IPCL has given us excellent results over the years with very good refractive outcomes and patient satisfaction and good vault prediction. And we've been happy with our outcomes. The newer lens, and I'll finish in a minute, is the presbyopic IPCL, which is, it was the first presbyopic IPCL which became available a few years back. It has been used quite extensively abroad and in India. And it has both the distance and the intermediate. So it's a trifocal design. And the 2 things have been merged to give a near add of about 3.5, intermediate add of 1.8, and it comes in several ads. So starting from an ad of 1.5 to 2.53 and 3.5. It ensures that from 5 to 9 rings for the ad are available, and gives very good results. This is the defocus curve of the presbyopic IPCL. And typically the strategy is that if the patient is under 45, you can do only one eye and slightly overcorrect these patients by putting the presbyopic IPCL. And then when the patient goes on to age and finds it uncomfortable, you can use the second eye as well, and then, correct it again, overcorrect it slightly more. So then it does well. But if the patient is over 45 years, then you can put a bilateral IPCL and do a little bit of overcorrection. And these patients typically go on to do well right till the time they get cataract with good vision. Of course, there is always the risk of getting glare and halos. And there are patients who complain of glare and halos. So one has to be very careful when offering this lens. And patient has to be highly motivated and understand the limitations of the technology as well. So some of the published data, there are studies which have been done which compare the IPCL with the ICL. There are other studies which have been done, and for long-term safety, which is done by Ramamurthy's group, and then another study which was done in keratoconus eyes. So they've all shown the IPCL to stand out quite well. And with that, I think I'll stop here. Thank you so much.
Thank you, Dr. Gaurav. I think you have covered, I think, the two leading phakic lenses. I think I spoke about the biotic phakic. I think you do use that, and also IPCL. These both results are very good, and I think you've been using last 20 years with the different models of whether with the columnar lenses or with the hydrophilic acrylic. Of course, those lenses also hydrophilic with the columnar coated lens. Is there any difference exactly, or all these phakic lenses are same?
So in my hands, I think technology has come of age, and today I can say that the Indian IPCL, the lenses which are both the biotech and the Care IPCL, they are giving us excellent results actually from all points of view, from refractive results to quality of vision and to the vault prediction. And in fact, they have more flexibility because they can you get the lenses much faster. So I typically will get a lens, from these people within 2-3 days. They keep a very good ready stock. The sizing is more flexible. So you have steps of 0.2. So you can customize the lens much better. And also off late, since we are doing intraoperative OCT, we typically order 2 lenses for every patient for 2 sizes. So on table, if we find that the particular first size implanted is having either a lesser or a higher vault, we can switch immediately to a higher sized or a lesser sized ICL. So that again is not Star is still not able to do that for us. So we find it very easy to use these, and of course these lenses are much more economically priced. So there is a barrier of pricing for some patients who will not be able to afford a Star lens. Then this lens is very, very affordable for many of our patients. Of course, the range of power, because the range of power is much more, and plus they are willing to customize. So many things that are much easier for these lenses.
Even they can customize up to -10, -12.
Absolutely, for very high astigmatism as well.
Yeah.
Yes.
Thank you.